Okay, so this, of course, is our review for the final exam, which is 100 questions. You get 2 hours to complete the exam. The others you get less time, so I wanted you to know that so you don't feel rushed. You do get 2 hours for the 100 questions. I want to show, but before we dive into the lecture, I want to point out what the rest of your assignments are going to look like, because you are going to have assignments throughout your clinical time and over the next couple of weeks before you guys start clinicals as well. So I'm going to share, I just want to make sure it's clear to everybody. And everybody except two have signed up for their NHA account login. And I'm sure those two will get to it soon. So when you log into your NHA account, and I would pull this up, but it looks completely different from a instructor perspective. The screens look very different. But when you log on to your NHA account, you're going to have our class there, our phlebotomy class there, and you will see where you have access to a total of 6 NHA practice exams, okay? So you have access to all of those. You don't have to pay for them or anything. That's included with the course. Those 6 NHA practice exams are going to be your assignments over the course of the rest of this class. Something important to remember, you do not work ahead on the NHA practice exams. The NHA page, if you were to do it, it would allow you to do them before they're assigned, but in the course, you do not want to do that. You want to stick with the schedule that you're given to on our online course. So let me share that. Does that sound good so far and make sense? Or any questions? Okay, good. And I'm getting this, oh, that's the wrong one. Okay, good. Okay. You guys tell me. I think that should be showing now. Okay. All right. So here we are on our course page. So let's say when I open week 7, you're going to take a look at week 7 and you're going to see that you have assignments. There are 2 assignments, okay? Really, they're both all about NHA Practice Exam 1. So you're going to see this, and what you're going to do is you're going to go to the NHA webpage and complete the first practice exam, okay? It is going to be due, you complete the first practice exam by Thursday, April 6th at 11:59 p.m. As soon as you complete that exam on the NHA website, you're just going to come right here, just like you've done an attestation, or you didn't do attestations, did you? Yes, you did for the Kahoot quiz. So once you've completed the first practice exam on the NHA website, you're going to come here, click this, and you're going to say, yes, I have done that, okay? Yes, I have completed the assignment. Oh, I'll try and fix this before you get there. That should say practice exam 1 or just I have completed the assignment. And you'll say yes, okay? All right, let's go back. Oh, so that's part 1 of the assignment for week 7. Part 2 is that you have gone to the focused review that is designed specifically for you based on how you performed on the first practice exam. So this is generated as soon as you complete that exam, it's generated again for you. And it has instructions right here that say how to find the focused review. So the second part of your assignment for week 7, due Sunday, April 9th by 11:59 p.m., is to go to that focused review and use it to study, okay? And I think I put study each week for roughly 5 hours, right, total. Now, that doesn't mean you have to do all your studying right after you've taken the practice exam. You can space it out throughout the week, but you want to make sure to use that focused review to help guide your studying. Once you have completed your studying for the week based on that NHA practice exam 1, you're going to again come here, click on this, and just do an attestation that you completed it. Let's see what this one says. Yeah, I'll fix the titles, but it'll just say I have completed the assignment. So that's it. Does that make sense for you guys? Or do you have any questions? And again, just like the attestation for the Kahoot quiz, you have to do both. And I know that makes it 2 steps for you, and I apologize for that, but there's no way for me to connect the NHA website to our course page. So you just have to remember to do the 2 attestations after you have completed the assignment. Any questions? All good. So is there a structured review after each? Yes, there is. So at the end of each practice exam that you do, like I was saying, it's going to generate a focused review that's specific to your test, how you did on that test. It's going to say like, oh, Kaylee, you did really well in this section, but this section you were lacking a little bit in your answers. So this is where you might want to focus your studies. Okay. All right. Perfect. The last thing I want to point out to you before I start lecturing. So week 7 and week 8 are going to both look like that. So you're going to have 2 parts to your assignment. Week 8 is going to be your second practice exam. Again, the exam is going to be due by Thursday. And then this focused review and study is going to be due by Sunday again. When we get into clinicals, so that's your weeks 9 through 15, it's going to look just a little bit different, but it's the same idea. And this is when you're going to do the remainder NHA practice exams 3 through 6 are all going to be here. You can see here, the only difference here is that I have I have combined the practice exam itself and the focus review into one attestation. And the reason for that is because you all have differing clinical schedules. So as long as you do the exam and you do the focused review after it, it's up to you when you do it. There's not that set exact date. The only difference is, you all have the same due date, but you could choose to do the exam and the focus review early in the week or in the middle, late. It doesn't matter. That part's up to you. Do you guys have any questions? If you do not do the attestation, I cannot give you credit. Feel comfortable with that? Okay, awesome. All right, so let's get on to our review for the cumulative final. All right, so let me get my notes here so I don't miss anything. Okay, so one of you tell me, what is HIPAA? Like, what's the main point of HIPAA? What does HIPAA do? And you can type it or you can put your speakers on. Patient privacy, exactly. So basically, it's designed to protect the patient and their information. It's a patient's right to privacy. And the important thing you want to remember is that it's also a need to know basis kind of thing. And what that means is if you don't need to know about a patient or about a specific part of that patient's chart, if it doesn't affect your care that you're giving your job as a phlebotomist, then don't access it. All right, what about Joint Commission? You remember what Joint Commission's main kind of thing is? That was back from chapter 1, so I know it's been a little while, but what about Joint Commission? Remember what they do? Improve healthcare. Okay, I'll accept that. They do. A Joint Commission basically accredits and certifies different healthcare facilities. So it's not specific only to us as phlebotomists or anything, but they accredit and certify healthcare facilities throughout the U.S. It's an independent, non-governmental, and nonprofit organization. And when you said they improve healthcare, you're right, because they create standards that focus on patient safety and quality of care. So more specifically than improving healthcare, that's what you want to remember about Joint Commission. Patient safety and quality of care are their 2 main focuses. Joint Commission also created the National Patient Safety Goals, which is a program with different goals to increase that patient safety. So they did create in that those goals, they did create some of the requirements and standards that relate specifically to us as phlebotomists. In particular was that 2-step identifier, which obviously does not relate only to phlebotomists, but that's something that we have to be really careful about. A big patient safety thing is that we're using a 2-step identifier for all of our patients before we go draw their blood or get their labs. Something important to remember, or let me ask you if you guys remember, what is one thing that you cannot use as a patient identifier? Let's say you're working in the hospital and you're going on the unit to draw blood. What is something you Exactly, room number. Good job. So you can't use room number as a patient identifier. There is also Joint Commission put that emphasis, and this applies to us as well, that emphasis in that open and active communication between the doc who's ordering the labs and those, us, the phlebotomists who are performing those tests. So it says if there's any questions, any doubts, we need any kind of clarification, Joint Commission says that we need to have this open communication with the provider. All right, who can remember what CLSI stands for? Tell me something about CLSI. Or, yeah, just tell me something about them that you can remember about CLSI. This is a big one for us. Clinical and Laboratory Standards Institute. Yes, exactly. And you can see there, clinical and laboratory standards. This is going to be more specifically for us as phlebotomists. So they develop standards and guidelines for laboratories specifically. They're, again, focusing on high quality care and these standards and guidelines to create quality of care through standardization, through making sure that we get the same result each time. Consistency, that was the word I was looking for. We want things that are consistent as well so that they're reliable. CLSI does accredit laboratories. They're in charge of making sure that labs have the most up-to-date information and that we're using the best practices, right? They regulate some of our standards as well, and the ones that they focus, or some of the standards that they regulate, are the additives in our tubes, what tube is the best tube for a particular test. They regulate the physical aspect of our job and such, like the angle of insertion when we're doing venipuncture, the location, the depth, things like that as well. And what you need to remember too, CLSI, order of draw, right? So of course, as we all know by now, because we do a lot of order of draw stuff in our assignments, is order of draw is to prevent that contamination from additives from tube to tube. A term that was in the NHA study guide. Now we talked about incident reports in lecture. What is an incident report? Just in general, what's an incident report? Reporting an accident. Yes. And even paper on what happened. Exactly. And even more specifically than that, or actually it's more broad, an incident report is done when there's anything unexpected that happens. So it could be an accident. It could be someone tripping and, twisting their ankle. It could also be an outburst from a family member that's a bit aggressive. So an incident report is anything unexpected that happens in the clinical or in our job setting. Now there's a term you want to know. It's called a sentinel event. A sentinel event is when something happens that results in either death, permanent harm, or severe temporary harm. So it's an incident, but it's more serious. It's a sentinel event. So an example of this would be, let's say a resident in the nursing home falls, and as a result of that fall, they die, okay? Another example, we're drawing blood and we cause permanent nerve damage. That's an example of a sentinel event. Let's see. Okay, somebody tell me what the SDS is. You can tell me what it stands for or give me a brief little what's in it. What is the SDS? Safety data sheet. Okay, good. Can either one of you just give me even a 1 or 2 word what's in the safety data sheet? This is from, I think, chapter 2, maybe. Safety data sheet. That could be in there. More broadly, it's any like chemical stuff regarding a substance. Yeah, I'll take that. That's perfect. So basically, any any like chemical or anything that we use in the lab. You know, it could be as simple as a cleaning supply that's used in the laboratory. It's got to be in the SDS. If it's in there, it's got to be in the SDS. Um, the the SDS is required by OSHA. What you'll find is the name of the chemical, the ingredients, the manufacturer's contact information, which is going to include name and address and telephone number. It's going to include emergency telephone numbers to contact should an exposure or spill or things like that happen. It's going to also, speaking of transport, it's going to include how to properly handle and store various chemicals and the actions that you should take should that exposure accidentally happen. So you want to know what the SDS is and what information is contained in the SDS. And it's those items I just told you about. All right, somebody tell me, what is a reference laboratory? What is a reference laboratory? Lab in the hospital. Kaylee, your answer is a little more clear because a reference laboratory is any laboratory outside of the facility outside of the facility where we're collecting the specimens. So let's say here at Pardee Hospital, I collect a lab, but for whatever reasons, because of this lab, my lab here inside Pardee Hospital does not have the capability to run that particular test. I send it to a reference lab. So a reference lab is a lab that is outside of where the specimen was collected. Does that make sense? So reference labs have a wider variety of tests that they can run. All right, so a healthcare associated infection. I just want to make sure you guys are familiar with that term. This is any infection that somebody gets while they're in a facility, and it's any healthcare facility. So it could be the nursing home, it could be the hospital. And the key here is that they came in for one reason and they have acquired this this infection in the hospital. It's unrelated to why they came in. So if I came in for it could be anything, I'm having a blank here, but if I came in for a wound on my arm and well, this doesn't even make any sense. I'm not using a good example, but let's say then I had to get a Foley catheter for some reason, and then I develop a UTI. So it's totally unrelated to what I came in for. That was a terrible example, but you guys get what I'm saying? That's a healthcare associated infection. All right. So tell me how long, yes, we watched a video on, okay, good. How long do you have to wash your hands for? What's the minimum? The minimum for a proper hand washing. Exactly, 20 seconds, good. All right, what is hemostasis? Hemostasis. Heme and stasis, hemo. Stopping the flow of blood, perfect. What is homeostasis? Homeostasis. Any thoughts? Homeostasis. So homeostasis is not specific to blood, but homeostasis is when everything's in balance. Everything is stable. All of our perfect balance. All of our body systems are working in a balanced, stable state. That's homeostasis. All right, so let's talk about real quick differences between erythrocytes, thrombocytes, and leukocytes. So erythrocytes, the other word for that, red blood cells, right? Thrombocytes, those are also our platelets, and they help, of course, with clot formation. Leukocytes, that's also white blood cells, and their main job is to help fight infection. Now I'm drawing a blank on which chapter it is that we talk about blood types, right? There is a video in that section, whichever week it was in. You'll have to go back and find it. But what I would suggest doing is just rewatching that video on blood donors, blood types, not blood donors, blood typing, and make sure that you understand what the universal blood donor and universal blood recipient are. Basically, O negative, because it has no antigens on it, is the universal donor, and AB positive is the universal recipient. You kind of want to understand how does this work a bit, and that's why I suggest watching that video one more time. Just kind of get be more comfortable with why one is the universal donor and one is the universal recipient. And when I'm talking about this, it's about antigens and antibodies. Like I said, type O negative blood has no antigens, so it's compatible with all blood types. The type AB positive has no antibodies against A or B blood and can therefore receive any blood type. I know that when you're talking antibodies and antigens, it can get a little fuzzy in the head. So after you watch that video, if you have any further questions, just send me a quick message and let me know. Even though we have universal donor and universal recipients, that's great for emergency transfusion purposes, but blood is always typed and cross-matched so that we can prevent any kind of transfusion reaction. So often as phlebotomists, we're drawing the type and cross-match. Path of blood to the heart. Make sure you review that as well. You have that nice little video in that section as well, that Amoeba Sisters video. Make sure you feel comfortable with that. Remember, of course, there is one exception to veins carrying deoxygenated blood and arteries carrying oxygenated blood. Do you guys remember which ones those are, the one exception to that rule? Arteries usually carry oxygenated blood to all of our body parts, and veins usually bring that deoxygenated blood back up to the heart to get oxygen. What is the exception to that? Do you guys remember? Correct. Pulmonary artery and pulmonary vein. No, that's okay. So make sure you feel comfortable with that and understand that. As you're looking at the flow and reviewing the flow of blood through the heart and the body, make sure that you understand why those are the two exceptions. So we talked about this in the previous lecture about why, but just for sake of time here, as you're reviewing that section, make sure you're making that connection. Why is this artery and this vein the exception to this rule? Okay. The largest artery in our body is the aorta. Our largest vein, the vena cava, just so you know. And that also, as you're studying that, reviewing that, you'll be able to visualize it as well. Who remembers what basal state means? Or anything about basal state? Basal state. I mean, an easier way to remember order of what veins. I don't know if there's an easier way. I'm trying to think if I had something else to say about that when we're reviewing. Let me look if I had any clues about that. No, not really. Let me get our image up and that might help. Hold on one second. I wonder if I still have it here. Bear with me for a moment. I mean, maybe you could come up with some sort of like acronym or something. I hadn't even thought about that yet. Let me see if I can find. Let me get my little image. Okay. I think for this, really you're just gonna it's just memorization. I mean, you got the median. If you look at this image too, it helps to remember, which is why I pulled it up. Because if looking at this image, you see what is, if you, the yellow there, those are the nerves, right? This median cubital is going to be our best vein, our first choice, right? Because it crosses across the middle. It's easy. It's pretty stable. It's easy to palpate. The cephalic is going to be the next one. And then this, even though it's not as clear here, it doesn't run quite as close to the nerves as the basilic vein. So that's going to be your last choice. So I don't know, maybe this picture helps to remember it, but I think it's more just kind of a memorization thing. And remembering when you review this, remembering, you know, like I said, median cubital is easier to anchor. It doesn't move around quite as much. That basilic vein, a little more difficult to palpate as well. So that's it's kind of just memorization. Early morning 12. Oh, you guys are back. Okay. So yes, we'll go back to that. Where was I? Basal state. So yes, so basal state is basically a condition of our body at rest and fasting. When are we going to be at rest and fasting? First thing in the morning, exactly. So even more specifically, when we're talking about basal rate, if we need to draw some labs on somebody when they're in a basal state, I think I just said rate, sorry, a basal state, you want to go into the room and basically, I mean, just wake them up just enough to get those labs drawn. Because as soon as we start to move and stretch, we've got that metabolism starting to go, and it's going to alter that basal state. So you need to not have eaten like 12 hours, like you mentioned. Yeah, just as they're waking up. Again, this gets a more specific reference range for an individual person. It's important to remember that we make sure we label our specimens before we even leave a room, right? You want to be in the presence of the person whose labs you just drew, but you also don't want to label before you actually get the blood. So just a couple reminders there. Therapeutic drug monitoring. What can you tell me anything about therapeutic drug monitoring? What it is or why we do it? Therapeutic drug monitoring. What does therapeutic drug monitoring have to do with? Yes, peaks and troughs. Very good. So basically, therapeutic drug monitoring measures the amount of medicine in the blood at a given time, okay? And 2 times when we're measuring it is at the peak and the trough. So what that is the peak is when there's the most amount of blood of that medication in the blood. The trough is the least. So these labs are extremely time sensitive, and it's really important that we, as phlebotomists, we draw these at the appropriate times. If I'm drawing a peak, for example, the doctor wants to know how much blood is, or how much medicine is in the blood when it's at the peak. Now, if I draw that at the wrong time and provide that information to the doctor and they base the dosing off of my labs that I've drawn, this could affect the patient, right? Because they're going to base their medications, their doses on these peak and trough levels. So the doctors want to know, are they giving the right dose of a medicine, and they're going to make their changes based on our work. A couple more terms to just review that I want to make sure you know. Exsanguination. That's when a life-threatening amount of blood is removed from the body. Iatrogenic anemia is anemia caused by either a large withdrawal, like a large amount of blood being withdrawn at one time, or frequent blood draws over a short period of time. Again, this is where that 10% of blood volume or more comes into play that I know you guys practice in class. Iatrogenic anemia is more common in pediatric or very small petite patients. Remember, if a sample is icteric, that can be a sign of hyperbilirubinemia, right? Or there's too much bilirubin in the sample. That's that yellowish greenish color. Bilirubin, like I was just saying, hyperbilirubinemia means the bilirubin levels are increased. If this sample is icteric, it could mean that there is a liver, or bile duct problem, or it could be an increased rate of destruction of those red blood cells. So just be familiar with the term icteric and hyperbilirubinemia and what that means, which we just kind of reviewed a little bit. What is the max amount of time that we can keep a tourniquet on in one, setting? Yes, 1 minute, exactly. When we say fasting, if someone needs fasting labs, what is it typically that we need to be considered fasting? Any lab. If we've said, if the order says, draw labs, or we need to fast before we have labs drawn, what's the time frame that is considered fasting, appropriate for a fasting lab? Does that make sense if I ask that? Yes, it is not eating, but for how long? Yes, exactly. 8 to 12 hours. Um, Again, if someone has came in, you say you're working an outpatient set. No, it's okay, Kaylee. I didn't ask it very clearly, I don't think. But if you're working in an outpatient lab setting, for example, and someone comes in and the order says fasting labs, and you ask them, have you been fasting? And they say, oh, yeah, I haven't eaten for about 5 or 6 hours. Then we need to get clarification from the doctor. Is this acceptable, or do we need to have this person come back again? Um, there are certain patients or scenarios where we're typically doing a dermal or capillary puncture versus venipuncture. What are some reasons why we may choose to do capillary or dermal versus venipuncture? Any examples that you can think of? Oh, well, it depends. I mean, if we have some veins that are difficult to get, right? And we need to do dermal puncture, but it also might depend on how much blood is needed for the sample, right? A lot of times you're seeing, if it just needs a small amount of blood and you don't need to do a venipuncture, we can do the dermal. An example of this would be like blood sugar, like you had mentioned earlier. Another time we're going to use these is if someone has really fragile veins, maybe because they're elderly. These veins are just really fragile, easy to blow. We could do dermal puncture. Another scenario where you see this more often is pediatrics. Now, of course, there's going to be occasions where we have to do a venipuncture, even in these scenarios. But these are some of the more typical reasons or patients where we could do a dermal and not have to do a venipuncture. If we recall, when we do a dermal puncture on an infant, right, we do it on the lateral plantar surface of the heel. If we do it in other areas, we can cause damage. In fact, we can even hit the bone if we're not doing it in the right location. That heel bone is called the calcaneus. So if you puncture an infant's heel bone, you can actually cause something called osteomyelitis. Osteobone myelitis, or itis, that you've got an infection, inflammation. So you can actually cause an infection of the bone if you hit the infant's heel, which is why it's critically important that we are doing our punctures correctly. Dermal punctures on adults, on the other hand, we're typically doing this on the third or fourth fingers, on the lateral palmar side of the finger. When we're doing dermal punctures also, so say my finger got punctured, I'm going to wipe away that first drop of blood before taking my sample. What else about dermals? I can't think of anything else at the moment. And I think I talked about venipuncture a little lower down. This might be a little bit, discombobulated, out of order. Hemoconcentration. Hemoconcentration is a accumulation of too much blood in one area. So hemoconcentration can happen for some different reasons. One of the reasons that we can have hemoconcentration is I asked just a couple questions back about the tourniquet. If we leave a tourniquet on too long, we can cause hemoconcentration. This is going to alter our test results. If we have the patient pump their fist, this can cause hemoconcentration. Remember, a squeeze and a hold is okay. That doesn't cause the same thing that it does if you're having them repeatedly pump. If we're doing a dermal puncture and you're like milking the finger, that can cause hemoconcentration. Just like the one squeeze and hold of the fist, you can squeeze and hold the finger and then release it, allowing it to refill back up naturally. That's different than that milking of the finger or the pumping of the fist. Let's see. So again, if we make some of these errors in our techniques and cause hemoconcentration, causing a change in the true lab values that we're drawing, this can affect the course of treatment for a patient, which is again why these things are so important and our technique is so important. Quality control. Quality control is how well instruments are working. I kind of mentioned this a little bit. We want to make sure that things we can reproduce accurate and reliable results. So quality control is making sure, are these things that we're doing producing reliable results? Let's see. Okay, so let's say you work in a lab where you have some CLIA waived flu tests. Let's say you grab a new box out of the office to use. What are some things that you need to do with that box of flu tests before you can actually use them? And again, this is talking about quality assurance, quality control. What are some things that you need to do? Yep, check the date, make sure it's not expired. What else? Control that, yep, do your controls, very good. Let's use, let's say there's some sort of any kind of equipment used, like for our blood glucose monitors. If equipment is needed, we need to make sure that it's, some of them get calibrated, like Biomed might come and calibrate them. We need to make sure they're up to date. And if we notice anything that looks damaged, or maybe it got wet or whatever, we need to be looking for these things. Basically for the exam, for that, the whole chapter on like quality control and quality assurance, maybe just go through the vocabulary in that section and just make sure that you feel familiar and comfortable with some of those terms. When you're palpating, can you guys hear me? I just heard a weird echo. Does it sound okay? Okay. Okay, good. All right, so when we're palpating for a vein, what are the 3 things that we're feeling for when we're palpating a vein before we stick? Okay, bounce or resilience, same thing, yes. So resilience or like that bouncy sponginess. What else? What do you need to know when you're feeling a vein? If you're going to stick somebody, depth, okay, very good. And one more thing. Okay, direction, exactly. Yeah, so we had that picture pulled up a second ago. If I'm going for a vein that's going, at this angle and I just stick straight up, I'm not going to get anything, right? So yes, so you're looking for the resilience, the depth, and the direction. All right, so a hematoma. A hematoma is when blood collects under the skin, right? It's a collection of blood in the skin and tissues. A bruise, right? If we puncture through a vein, we're going to have blood leaking into the surrounding tissues. This can also cause, can cause bruising. It can also cause a hematoma. If another way we can cause a hematoma is if let's say I have my tourniquet on, I just drew my blood, I took out my needle, I'm done, but I forgot to release that tourniquet first. So if I still have that pressure being applied and no needle and tube there, I can cause bleeding also into the surrounding tissues and skin. So those are just a couple ways that we can cause these bruisings and hematomas. Phlebitis. Do you guys remember what phlebitis is? What that word means? Phlebitis. exactly. Inflammation of the vein. Again, itis is your key there of like inflammation. It can be Phlebitis can be caused by trauma to the vein, but also important to know that certain medications can cause phlebitis. Um, let's see. Hemolysis. What is hemolysis? Lysis is a key part of that word there, and hemolysis. Can you remember what that is? Hemolysis. Yes, very good. So hemolysis is basically the destruction of red blood cells, and this happens for a variety of reasons. But we do need to prevent hemolysis from happening um, as a result of our improper technique, handling, etc. So if we don't handle the specimen gently, we can actually cause hemolysis. If we don't use the correct size needle, if we don't allow the alcohol to dry thoroughly before we draw the blood, that can actually cause hemolysis as well. And of course, as you guys know, any alteration to these specimens that is caused by us is not going to give accurate results. So maybe I already said this in one of my lectures, but I went and had some labs drawn, a few weeks ago or something, and the phlebotomist she took her alcohol swab, went like that, and then she grabbed a gauze and dried it off. Is that before she drew my blood? Is that appropriate? Tell me what's wrong with both of those things that she did. Yeah, exactly. And not only was it not 30 seconds, she did one swipe down my arm. She needed to do the concentric circles for a good 30 seconds with force and friction, and then allow it to fully dry, air dry. She grabbed a gauze and wiped it off. She just recontaminated the site that she just semi tried to clean, right? So make sure you understand how to properly clean a site as well. Let's see. La yeah, I didn't, and I feel I and I actually have felt really guilty about that. I really should have stopped her. Um, I know, I should have. Like, I still feel like I did something wrong. In fact, I was considering calling them and just saying like, "Hey, I'm not trying to get anybody in trouble, but I just wanted to let you know because that's not safe for patients." And part of the reason I went is because I was not feeling well, and so I will say I was not in my full state of mind. But yeah, it's bothered me from just a couple weeks ago. So I really do think I'm going for my own peace of mind and knowing that I'm um, preventing her from making an error moving forward. I'm going to call the office and just mention it to them, because we need to advocate for ourselves, and we need to advocate for other people and patients. So yeah, yes, I'm going to. Yeah, so just if you see an error ever, you really should, absolutely. And we can do these things in a respectful and professional manner, right? You want to, say like, "Hey, just so or hey, do you remember that?" There's ways, and trust me, I've working on the floor as a nurse for, 15 years now. There's been situations where you have to address some of these things with coworkers. But when it comes to patient safety, it's really important that we do that and that we advocate. So yes, I will, I'm gonna do it today so I don't put it off. I'm gonna call today. But yes, so make sure that you always are cleaning appropriately and doing what you're supposed to do. Um, okay, just some examples. I have 3 lab specimens that always require immediate placement in a slurry. And I mentioned these 3 because these are the ones we see most commonly: lactic acid, ammonia, and bilirubin. Um, of course, when we're talking about order of draw, you guys are getting more familiar with that: venipuncture, capillary, the tube colors, their additives, their actions, and some of the common uses for the various tubes. You guys have gone over this several times. And like I said in one of my lectures, we're learning per the NHA guidelines. When you go off to your own facility and when you go off to clinical, you are going to see some variances in differences in what tubes are used for what tests, and you of course are going to go with your policy at your facility. Again, we're teaching for NHA tests so that we can go by their guidelines. Patient Bill of Rights. The patient's Bill of Rights is rights that we have as a patient in a facility. It basically is how we should be expected to be treated and what our rights are. Bill of Rights are always posted, on different walls. If you go into a nursing home, they're given to the patient and family at the time of admission. So just know what patient Bill of Rights is. When we centrifuge a specimen, we're spinning it so it's separated into its different components. Typically, we centrifuge within how many hours of collection? Do you guys remember? Typically we're centrifuging within, it's actually, you have a little bit more time, typically within 2 hours. I'm not going to say your answer is not incorrect, but typically within 2 hours or less is appropriate. So that 1 to 2 hour window. Blood cultures, we talked about that kind of recently. That's when we're looking for bacterial infection. There are special considerations for cleaning the site. It's not just an aseptic like we did with the alcohol swabs, but it's a sterile clean that we need to do. So this is when you're going to see, like, you may clean sometimes. The NHA also states, you'll see this, so remember this for NHA specifically. They'll state a 70% alcohol cleanse followed by chlorhexidine. So some places you'll just see the chlorhexidine. NHA, you may see that 70% alcohol followed by chlorhexidine. And don't forget this when we're doing aerobic followed by anaerobic. Who remembers what the term aliquot means? We've covered a lot. Do you guys remember what the term aliquot means?
Isn't it like when one, like, the answers over time are different than the one you just got?
No, when we're talking about aliquot, that is when, I don't think so, unless I'm just misunderstanding, but like, let's say I just centrifuged a specimen and it's separated into its 2 parts. When I make aliquots, that's when I'm taking out and separating those 2 samples. So I might have my tube with the two different parts, mixing tubes or transferring into different tubes. Yeah, so I might take the top layer of that specimen and put it into one container for further testing, and then I'll take that second part of the specimen and separate it into another. I'm making aliquots. I'm breaking it into its parts. Yes, exactly. Thank you, Kaylee. Yeah, dividing the specimen, exactly. So 3 terms that you want to make sure you know. I'm jumping around a little bit here. I know, I apologize. Battery versus assault versus abuse. What I want you to remember is that abuse is mistreatment that causes physical, mental, or emotional harm. So it kind of covers the whole spectrum, right? It could be physical, it could be mental, it could be emotional. Assault is when you make a threat of physical harm. You've made the threat, but you haven't actually touched them. That is assault. Battery is when you actually make physical contact. So not only do you say, I'm going to tie you down if you don't stop moving around, you actually tie that person down. More often than not, battery happens in the moment. It's not normally like a premeditated thing, but you want to make sure you understand the difference between those 3 terms. Pardon me for 1 second. 30. Okay. Let's see. Don't forget that the royal blue, the takeaway that NHA wants you to have is that royal blue tubes are trace element free, and that they'll be labeled. If they have an additive in them, it'll be labeled, and you'll read on the label what additive is in that tube. You guys want to remember, this was on one of the tests, the 3 layers of all of our vessels, right? The tunica intima, tunica media, and tunica adventitia. You guys also want to remember what the 6 links in the chain of infection are. You've got your infectious agent or germ, pathogen, the reservoir, right, where it lives, it's its home, portal of exit, how it gets out of my body, for example, to be spread to other people, the mode of transportation, is it contact, is it airborne, is it droplet, the portal of entry, which is the same as the portal of exit, it's just that the germ is getting in, and then a susceptible host. And that's a susceptible host, of course, is someone who, for whatever reason, lots of varieties of reasons, can't fight off that particular germ or pathogen. What's the lumen? If I'm talking about what is the lumen? This was, I think, on one of your tests. So I'm trying. See, tell me if you can tell me what that. What am I referring to? You guys remember this from it goes along with uh like the vein, the layers of the vein too. So the lumen is like the yeah, okay, that's great. So lumen is like the opening. Okay, so our veins, the lumen is that opening in the veins. The gauge of the needle of a needle tells us the diameter of the lumen. So the diameter of that opening. Yeah, exactly, or intestine, exactly. So when we're talking about gauge, which I'm going to make sure I don't say this in a confusing way. Which gauge has a bigger lumen? A 16 gauge or a 21 gauge? Yes, perfect. Okay. I'm glad I asked that in a way that made sense. So just remember that the smaller the number, the bigger the gauge, the bigger the lumen. When we insert a needle into our patient to draw blood, what do we need to know about the bevel? And what is the angle of insertion? Bevel up 30 degrees. Okay. So there's actually a range to the angle. You're not wrong. You've got that. You've got part of the range, but there's actually an angle of insertion. There's a range in degrees. Nope. It's going to go the other way. Mm-mm. So think about if you're doing like the hand, you're going to probably go at a much less of an angle. So it's actually 15 to 30. Okay. So remember that. The angle of insertion for venipuncture is 15 to 30 degrees, of course, depending on the depth of the vein. Yeah, yeah. So, and you got that right with bevel up. That's correct. Bevel up 15 to 30 degrees. When we talked about the three circulation systems of the body, which of course all work together, what are the three circulation systems of the body? Three circulation systems of the body. Systemic, yes, good. Two more. Coronary and pulmonary, yay, very good. Obviously, it all combines into one, but those are the three systems that work together to create our circulatory system. So I went kind of quick because I was worried about time, but we're actually good because that's the end of my notes. And we're finishing almost exactly right on time. Do you guys have any questions about anything there, about anything that's going on or coming up or whatever? If you don't have any specific questions right now, okay, then you are good to go. As you're, can you? Yeah, you can. You can do that. You can kind of pinch those wings together to go in. That's going to give you some good stability. Yes. Have you guys practiced with the butterflies much in class yet? Okay, good. Okay. Yeah, and you can and when you guys get it's in class next week. What is next week for you guys for skills? I have to or Oh, yeah, that's right. Good. So live sticks are going to be happening next week. Really exciting. Don't hesitate to though if you want to get a little more practice with the butterflies. Maybe ask because I think there's going to be still. I'm pretty sure that Kirsten and Michelle and maybe even Heather are going to be there. So maybe one of them could kind of take you guys aside to do a little more practice. But it's up to them, of course. I don't want to promise something that I can't uphold since I'm not there, but don't hesitate to at least ask if there's some more things that you want to get a little more hands-on practice with while the others are doing their live sticks. Any other questions? Perfect. Well, that's great. I'm glad you guys are getting 2 weeks of live sticks because depending on how classes go, some classes don't always get 2 weeks of it. So that's really, really awesome that you guys have gotten far enough along to where you get 2 weeks of that. So that's great. I know, I would be too. And it's if you're and some people aren't nervous, but if you are nervous, it's totally normal to be nervous for that first 1 or 2 sticks. Totally normal. I'm looking at I was just looking at the quick dates reference real quick. Let's see. Yeah, and then you guys start. And I know everybody, of course, has their clinical assignments. Are you guys excited about that, or any questions or anything about that as well? Yeah, it's all right to be nervous. All right, I'm going to stop the recording too, just because then doesn't need to be so long.